Okay, so good morning to everybody. First of all, I would like to thank the organization. I must say that, this presentation has been quite a challenge because trying to summarize all papers in stroke prevention has been quite difficult. And actually, when I type, in PubMed stroke prevention, they show up more than 2,500 papers. So what I did, actually, is try to, classify these papers in 5 sections. The first one, it's epidemiology, pathophysiology. Second one, it's oral anticoagulation. Third, left atrial appendage occlusion papers. The fourth, it's this therapy in specific settings. And finally, I'm going to present data that has not been published yet, but I think that it's important to mention. In the first section, I select just this patient to highlight and confirm something that we need to repeat once and once and once and once. It's that AF strokes are really devastating, and it's something that we really need to prevent at all costs. So in this paper published in Stroke, so what they did, they follow AF strokes for 5 years, and actually what they saw, that only 39% of the patients were alive, after 5 years, after AF strokes. In addition, almost 22% of the patients presented a recurrence of ischemic strokes, okay? And of the survivors, 44%, okay, were independent after 5 years. And if we take the whole cohort, only 14% of the patients were alive or independent after these 5 years. So something, I think that it's really stunning, this paper, and highlights again, like the need of prevention. The second part is talking about oral anticoagulation, okay? And here I want to highlight a second concept, okay? That the compliance of oral anticoagulation, it's really low, okay? In this paper that was published in the European Journal of Neurology, they analyze, okay, the compliance of anticoagulation in different subtypes of patients. And as you can see, they identify subgroups with a low compliance. Actually, that's in gray, you can see the patients with paroxysmal AF, with a Hasbled more than 3, with previous bleeding, alcohol abuse, sinus rhythm, and no previous stroke. All these patients had a compliance of less than 50%. And patients with previous bleed and alcohol abuse, it was less than 30%. Again, I think that an important concept that although we prescribe, these patients probably are not going to take it. The second paper of this section, it's a survey. And again, I think that it's nice. It was a survey published in the Canadian Journal of Cardiology. They did, a part of the physicians, surveying physicians, and another in the patients. I focused just only on the patient section. And they asked the patient, during the last week, how many doses of your anticoagulant have you missed? Here in the left side, okay? And you can see that 30% of the patients taking apixaban and dabigatran, just only 1 week, they miss at least 1 pill, okay? On the right side, you can see that 30% again of patients with apixaban and dabigatran, okay, were taking a wrong dose. They're taking actually the pill once daily, for the rivaroxaban 6% twice, and for the warfarin 14. So again, it's not only that they don't take it, it's just that they take it wrong. Okay? And finally, when they ask, are you considering to stop the medication? This is just 1 year. The overall answer, yes, was in 17. And the group that, they consider more to stop this medication was the apixaban group with 27. Okay? Now I will move to the therapy, actually. From this section, LAA Occlusion, in general, I selected 5 papers, 3 registries and 2 meta-analyses. The first one, it's a multicenter experience with the unplastered cardiac plaque, published in Eurointervention by Dr. Zikas. This is, the largest registry available so far with the ACP. It's 1,047 patients of 22 centers. The procedural success was really high, 97, and the adverse events were 4.97, and with a mean follow-up of 1 year, the rate of strokes and TIAs were low, and the rate of measured bleeding were also low, 1.5. So when they analyze what they observe compared to what they expect, okay, based on the chats for stroke prevention and based on Hasbled for bleeding, and they saw that in the total population, on the right side, in blue, and the total reduction was 76, Whereas, if you follow these patients after 1 year of the therapy, the benefit increased to 81%. For the Hasbled, exactly the same. Total benefit, total reduction, 77. And if you follow the patients after 1 year, the reduction of bleedings, 90%. The second one that I picked, it's the Iberian registry published by Dr. Lopez Mínguez in Heart. It's a registry with a longer follow-up, 2 years, with 167 patients treated with the ACP system. And again, they show nice results. The stroke rate after 2 years was 4.4, so 2.2 per year. Major bleeding 5.7. The mortality was high, but actually the cardiac mortality very low, 1.3. And he saw exactly the same that Dr. Zika saw with this large registry, that the annual risk reduction observed versus estimated, was really talked in favor of the therapy, reducing the rate of stroke and bleeding from 2.4, that was the observed, versus the 9.6 that was the expected, and bleeding 3.1 versus 6.6. Moving to the Watchman field, so this is a registry that has been recently published in 2016. It's the Evolution Registry. It's, again, a large registry of 1,021 patients undergoing LAAO with the Watchman device. What is interesting that it's very contemporary, It's, from October 2013 up to May 2015, so are, current numbers. What it's also interesting that the population, although Watchman, it's very similar to the ACP, higher risk, CHADS score of 2.8, CHADS VASCO 4.5, and Hasbled of 2.3. 61% of the patients were not eligible for oral anticoagulation. And what they saw, on the right side, the evolution numbers, that the procedural success implantation, was achieved in 98.5% of the patient, showing an improvement, in the successful rate, compared to the previous studies. And according to the serious adverse events, they went really low, from PROTECTA-F, CAP, PREVAIL, so up to 2.7. So I think they are important numbers. The two meta-analyses that I want to present you and show are about, the first one about Watchman, so they collect the population from PROTECT, PREVAIL, CAP, and CAP2, accounting for a total of 2,406 patients with a mean follow-up of 2.6 years. And what they saw was that in terms of efficacy, preventing all stroke or systolic embolism, the therapy was as good as warfarin. But the therapy was better in terms of reducing hemorrhagic stroke, reducing cardiovascular and unexplained death, and reducing major bleeding after the procedure. This paper, I think that it's also important, published in Heart and Rhythm this last year, and actually what they compare is the therapy with NOACs, with novel oral anticoagulants. So they divided into analysis, the randomized trials, they were 6. Of course, it's the Watchman population, and people without contraindication to oral anticoagulation. And in this setting, in this population, they did not demonstrate superiority to NOACs. But if we move to the observational studies, including patients at higher risk, including all the Amplatzer or the ACP and Amulet studies, meaning heterogeneous population, higher risk of bleeding, what they saw is that LAAO show lower rates of both thrombotic and hemorrhagic events compared to NOACs. So I think it's an important message, this one. Fourth section, LAAO in specific settings. First of all, I would like to talk about chronic kidney disease. This this meta-analysis has been published in CHEST, and I think it was important because it's huge. We're talking about, 48,000, more than 48,000 patients, and more than 11,000 patient warfarin users in chronic kidney disease. So what they saw, talking about stroke and TE prevention, the upper part of the table, that patients in non-end-stage chronic kidney disease, there was a benefit, of taking warfarin. So the lines were on the left side. But patients on dialysis and end-stage CKD, that benefit was not there. The patients did not benefit from taking warfarin. In addition, when analyzing the measured bleeding, in the non-stage group, non-end-stage, chronic kidney disease, there was a tendency to bleed, but not significant, and in the end state, the dialysis, yes, okay? So the patients bleed more. So for those patients, I mean, there's no benefit of warfarin and more bleeding, so there's a clear need for alternative therapies. And this is what, it's going to be presented by Dr. Keffer during this meeting. So Dr. Keffer analyzed, the impact of chronic kidney disease on left atrial appendage occlusion for stroke prevention. I'm not going to talk about that, but I think that, are promising results. The second setting that I want to talk about, and actually Dr. Wester talked a lot, it's intracranial hemorrhage because it's another setting that it's important for us. So he already mentioned that after intracranial hemorrhage, the risk of having ischemic stroke, it's much higher. It doubles. Okay, so it's something that we need to keep in mind. Second thing that he also mentioned, that from the Danish national cohort, that those patients would benefit from taking oral anticoagulation in terms of ischemic stroke prevention and systemic embolism, because the oral anticoagulation reduces those events and also reduces the mortality. But what's the problem? The problem that's also highlighted in the Swedish registry, that only 11% of patients that have bled, are taking oral anticoagulation. So again, a setting that need, an alternative therapy. So we already have, a small answer, but the answer, okay? So Dr. So's group published this year in Canadian Journal of Cardiology their experience with LAA occlusion in intracranial and ocular hemorrhage, 26 patients, different devices. They didn't observe any adverse event, and with a mean follow-up of 13 months, they had 1 non-cardiovascular death, 1 TIA, and no device thrombosis. What is interesting, it's the treatment that they gave after. So dual antiplatelet therapy in half of them for 1 month, and the same therapy for 3 months in the other half. Some patients had different regimens, but these two therapies were the most commonly used. And finally, I would like to highlight that this has been not published. This is the introduction of what I'm going to present. I hope that it's going to be published this year, but I think that it's an important concept. So we all know that in general, inside the left atrial appendage, the thrombotic burden, it's large. Okay, but we know what happens before closing the appendage, but we don't know what happens after closing the appendage. Actually, we know a little bit, because data from PROTECT-AF and CAP registry seems to suggest that the strokes after closing the appendage are less severe. So here you can see, one of these tables of these M2 papers. MRS means modified ranking score. It means, the severity of the stroke. Okay, so an increase, higher increase means higher severity. So if you compare Watchman with warfarin, you can see that in the warfarin group, there's always, higher numbers, meaning, more severe strokes. In this paper as well, published in JAMA, you can also analyze the disabling strokes specifically, and you can see the rate of disabling strokes in the device group was 0.5, and in the warfarin group, 1.2. So it was more than double. Again, highlighting the fact that they seem to be, strokes after closing, they seem to be less severe. And actually, it seems logical, okay? Because if we block, the appendage, okay? So the thrombotic burden, it's going to stay there, and what can form outside, actually it could, seem to be, smaller. However, as you can see here, over a device, because this is an occlusion device, like device thrombosis and things might happen inside the left atrium. So some specific analysis, after this therapy was deemed necessary, and it's what we did. Using the ACP multicenter registry, we specifically analyze strokes and TIAs. We, of course, analyze the modified ranking score. For the ones that are not familiar, 2 means slight disability, so the patient is unable to carry out all previous activities, but able to look after own affairs without assistance. So it's autonomous. So the definition of non-disabling stroke, it's at 3 months, 90 days, and from 0 to 2, it's non-disabling, and from 3 to 6, it's disabling. So the clinical follow-up was available in 90.2% of the patients with an average of 13 months. Dual antiplatelet therapy was the most common antithrombotic therapy after LAO with an average duration of 3.8 months. 1 year all-cause mortality was 4.3, And at follow-up, we identified 18 cerebrovascular events, 1.8, 9 strokes, 9 TIAs. 0.5% of the patients presented already history of a stroke and previous TIA, and 2 patients had already, and were disabled, so were, excluded from the analysis because they were already disabled. Okay, so disabling cerebrovascular events were only found in 19% of the patients. Just only 3 patients presented disabling events, repeat, MRS less than 3 at 3 months, okay? There were no hemorrhagic strokes. The median time of stroke TIA presentation was 420 days after the therapy. 94% of the patients were on single antiplatelet therapy when the cerebrovascular event occurred. Overall, patients had a good functional recovery after stroke. Neither device leaks or device thrombosis were related with that, okay? We didn't find a significant association. So this is the graphic of the functional recovery, left baseline, the presentation, and you can see how, the patient recover. In blue, strokes and TAs together, in red, just only strokes. So in conclusion, according to our results, cerebrovascular events after left atrial appendage occlusion were infrequent and mostly non-disabling. And of course, further studies with randomized data and independent event adjudication will be necessary to confirm the results. Thank you.